I guess we can go ahead. So, good evening and welcome to the second session of I Communicate. On behalf of Navor's, I would like to thank everyone for being here despite being late and after a long day of clinics. So, it's our great pleasure to be working hand in hand with the American Society of Ophthalmology under the umbrella of the American Academy of Ophthalmology to develop a workshop to enhance doctor-patient communication, which I believe one of the main challenges that you face on your daily practice, and with an ultimate objective to finally improve patient outcomes and patient lives. It's our great pleasure to have Dr. Maysoon AlKaram with us, which is the head of the Culture Committee in the American Society of Ophthalmology. And with no further ado, I'd like to introduce her. And Dr. Maysoon, the floor is yours.
Thank you very much, Shurooq, and a very good evening for UAE time for our guests who are joining us from UAE, and good afternoon for our US speaker who are joining us from US. It's my great pleasure actually to be moderating this second series of I Communicate workshop that was developed by the American Academy of Ophthalmology. I think the first series of this I Communicate had addressed the diagnosis of the wet AMD, and the second series of tonight is under the title of Communication Saves Vision. I think it's aimed at enhancing doctor-patient communication and addressing the treatment challenges specifically in neovascular AMD and intravitreal injections. I would like to take this opportunity to thank Novartis for sponsoring this series of workshops. And this, as Shurooq have mentioned, this workshop is supported by the Emirates Society of Ophthalmology. I don't need to emphasize on how important is the effective communication in managing patient expectations. That should enhance our relationship with our patient, and that should be reflected on the patient compliance, on the treatment and the visit, which we hope that it can improve treatment outcome. I don't want to take a long time in this introduction, and I would like to introduce my iconic speakers who are joining us from United States. I'll start with Dr. Christina who is an associate professor of ophthalmology and program director of VR diseases and surgery fellowship at the Baylor College of Medicine in Houston, Texas. Dr. Wang completed her ophthalmology residency at Wilmer Eye Institute in Johns Hopkins University and surgical retina fellowship at the Bascom Palmer Eye Institute in Miami. She's involved in multiple clinical trials, and her academic interests includes clinical and surgical outcomes, healthcare economics, and telemedicine. Welcome to our presentation today, Dr. Wang. And I would like to also welcome and introduce my second speaker, Dr. Fortune, who is an associate professor of ophthalmology at Bascom Palmer Eye Institute of University of Miami. Dr. Fortune serves as a medical director of the Bascom Palmer Eye Institute and Ambulatory Surgical Center in Palm Beach Garden. Dr. Fortune area of practice is the medical and surgical management of diseases of the macula and retina, as well as the vitreous. Dr. Fortune as well served as a principal investigator in a number of national and international clinical trials. He is as well a board of the. He's also as well on the board of VBS Society and the chair of the Pan American Association of Ophthalmology, a young ophthalmologist section. Welcome, Dr. Fortune, to our tonight's workshop. I would like to, prior of starting of our program of tonight, I'd like to present a few slides on the result of a survey of I Communicate program. Just let me share my screen. Is my screen visible for everyone?
Mm-hmm.
Oh, sorry. Okay. This survey was a collaboration between Novartis in partnership with American Academy of Ophthalmology. And the purpose of this survey was to summarize the local prospect of our Gulf ophthalmologists on the challenges and concerns or unmet needs while communicating with their wet AMD patient on their treatment initiation of anti-VEGF. This survey was conducted and sent to the ophthalmologists in the region. And the result of the survey was as well shared with the our speakers from tonight in the American Academy of Ophthalmology, so they can customize their presentation and their slides to give you a unique.
There's another table of even more studies.
I think there is someone's mic is on.
I'd like to highlight a couple of those that I think are particular.
Thank you very much. So in order for them to give you a unique and custom-made presentation. The survey actually included 13 questions. To not bore you all with the questions, we've chosen a few of those questions and I'm sharing the result with you. So the first can we unmute? Thank you. So the first question was, what are the criteria and factors you look for in an ideal neovascular AMD treatment to satisfy your patients' unmet medical needs? Majority of the ophthalmologists have thought that the visual outcome is a very important factor that that satisfies their patient. Second comes the safety of the treatment. Then the central subfield thickness as well as the patient compliance. The second question was, what are the challenges you face when you do communicate the treatment plan? Majority of the ophthalmologists, or 50% of the ophthalmologists, have thought that the patient commitment to the treatment plan represent the most challenging part of the treatment. And then the insurance and cost represented as well of 44% of the responses. Then comes the patient anxiety as well as the patient doubting the treatment efficacy. The third question was, what are the main patient concern about the treatment? 50% of the response which we got in the survey was the main concern of the patient is, will this treatment cure me? Then it comes the frequency of the appointment, the side effects come later, as well as the insurance coverage and costs. The fourth question was, what drives you to switch the treatment? We had a few options in the survey. One of them was low VA, high central subfield thickness, or presence of the fluid. The third choice was all of the above. And majority of the physician or the ophthalmologist have chosen the three parameters as a reason for them to switch their treatment. The fifth question was, what is your winning strategy to manage patients' fear and anxiety of the first injection? This a bit of a quotes from the ophthalmologist who participated in the survey, like explanation in details, proper counseling, reassurance of the patient, I do it myself, the result after the first injection, and the efficacy and benefit of the treatment. That was a quote from the ophthalmologist who participated in the survey. Let me stop sharing my presentation. So with no further ado, we'll start with our first topic in our agenda, which is a step-by-step approach to discuss intravitreal injection with the first-time patient. This talk will be presented by Dr. Weng. The floor is all yours.
Thank you, Dr. Maysoon, and thank you for that kind introduction, and also to all of you for being here with Dr. Fortuna and myself on a very late evening. And we'd also like to thank Novartis and in conjunction with the American Academy of Ophthalmology for inviting us to be here today. Excited to share this. I think this is a really important topic that we're focusing on, which is patient-physician communication. It's everything to the success of a treatment regimen with intravitreal injections, as you all know. So I'm excited to present this next short set of slides. I do want to keep this interactive. That's one of our goals tonight. So I know that the only people on camera are us, but please feel free to use the chat. I'm going to ask you for some of your input later on in this deck. I think one of our kind of most impressionable moments is when we first tell patients that they need intravitreal injections for that very first time. And it evokes a lot of fear. There's a lot of shock, sometimes even denial. And so I wanted in this first talk to really go through a step-by-step approach for how to discuss intravitreal injections with first-time patients. And this is something I hope that you'll be able to take back to your practices and patients. So the objectives are to enhance patient-physician communication skills when discussing intravitreal injection treatment, and to understand what actions can foster patient awareness of their condition and trust in your care. That's what we're trying to achieve today. Let me start off by a patient scenario. This is all these examples that I'm including are real patients of mine. So this is a 79-year-old male, blurry vision in his right eye for 2 weeks. He does have a history of hypertension and coronary artery disease. He's been diagnosed with dry macular degeneration for the past decade, and he's also pseudophakic. His mother did go blind from wet macular degeneration. He smokes a pack a day, he's retired, and he does take AREDS vitamin supplementation, although he admits that it's pretty sporadic. He's not regular with that. And so as you can see from his fundus photograph and OCT to the right, there's a diagnosis that I think all of us are comfortable making, which is that he's had a conversion to the exudative or wet form of macular degeneration in his right eye. And you can see his vision has gone down to 20/70 from his baseline. So how do we approach this? I remember when I told the patient, this is the treatment that you're going to need. It's going to involve injections in your eye. Like many other patients, he was alarmed. He said, "What? I need an injection in my eye, a shot in my eye? How does that work? That sounds terrible." And so I want to break it down now into 5 different steps and go through points that I try to convey to the patients through each of these steps. And then I also want to take you through some real life conversations of how that discussion usually goes between myself and my patients. Not to say that that's the best way, but it's one way that's been effective in my experience. And hopefully you can draw from that and sort of modify it to your own. The 5 steps are really, number 1, sharing a diagnosis with the patient, reassuring them. Second is to introduce the thought of intravitreal injections to them and to set expectations. That's so important. The third, I like to really spend time to talk about the procedures step by step. So I find that alleviates their fear. Fourth is to emphasize that it's going to be a long-term therapy and also to remind them of what can happen if they terminate early. And then fifth is to answer any questions that they have and provide take-home resources for them. So we're going to go through these now in detail. The first step, as I mentioned, is to share the diagnosis and reassure the patient. I would recommend, first of all, don't keep the patient waiting for their diagnosis. As soon as I finish my examination and have looked at the OCT and I know it's a diagnosis of wet AMD, I tell them that, because oftentimes they're very worried about that already. They may have had a family member who's had it. That's their biggest fear, and you don't want to linger on that. So I often just tell them straight out. And I use both medical and lay person terms to avoid confusion. So a lot of us will say this is the wet form of macular degeneration, but I actually will also tell them sometimes it's referred to as exudative or neovascular macular degeneration. That way that avoids confusion when they inevitably go home and start Googling it and looking up information themselves. I like to use models to guide the discussion, like you can see to the right there. I think that's really helpful. A lot of patients, remember, they don't even know what the retina is or where it is. And I like to help them remember and retain information by bringing in some of their support members, such as family or friends. I try to elicit how much information they already have about the disease. Some people know a lot, some people don't know much. And so I'll ask them if they've ever heard of that diagnosis before, or if they know anybody with that diagnosis. That also helps to draw out some fears and concerns on behalf of the patient. And then I provide reassurance. I tell the patient they didn't do anything to bring this on. I think that it was a genetically determined disease. That way they don't think that they did something wrong. If their other eye is dry with good vision, I remind them of that. If they have an affected family member like this patient did, I'll tell them that we are in a very different time. A lot of times they think, oh, well, mom went blind from it, so I'm going to be going blind. And that is not necessarily true these days, thankfully, with all of our effective treatments. If the disease has been detected relatively early, I'll tell them that. I'll tell them you did the right thing by coming in, just to give that reassurance. And I'll also remind them that we are going to be initiating treatment right away. And that usually gives them some relief that we're about to do something. So please bear with me. Normally my slides would not look like this, but I thought for this type of presentation, it's really helpful not just to go through bullet points like I just did, but to show you how I actually roll that into a conversation with patients. I'm going to do a little bit of the blue is the physician, the green is the patient, and I'm just going to read through this briefly. So I usually start off by saying thank you for bringing your wife into the room, since 2 sets of ears are better than 1. Well, Mr. Jones, I've examined your eye and your pictures, and it looks like the reason for the blurry vision in your right eye is because your dry macular degeneration has turned into the wet form, sometimes called neovascular age-related macular degeneration. Have you ever heard of that before? Well, that's what I was afraid of, Dr. Wang. My mother had that and went blind, and I knew that it would happen to me one day. Am I going to go blind like her? Let me first reassure you that it's a very different time compared to when your mother was diagnosed. We now have excellent treatments that are very effective at helping patients maintain their vision. Additionally, we've caught your wet AMD at an early stage, so I think there's a very good chance that we can help keep the vision that you have now and maybe even improve it. Let me explain a bit more about what wet AMD is and how we treat it. Take a look at this model eye and your pictures from today. Wet AMD is not uncommon and happens more frequently as we get older. You did not do anything to cause it. It is something that happens due to the genes that we are born with. Small deposits form under the retina, and sometimes abnormal vessels begin to grow, causing fluid to gather in the retina. We can't make the deposits go away, but we want to do everything we can to treat the fluid that's there. The sooner we get the fluid under control, the better your chances are of preserving your vision. So I'd like to start treatment right away. Thankfully, I looked closely at your left eye, and you still have dry AMD on that side with excellent vision. So I want, through all of these conversations, I'm going to show you 5 of them today. I'd love for you to input your opinions in the chat. Let me know if anything that you would have phrased maybe differently, and maybe pick up some of the phrases that I've used that reflect some of the positive and recommended approaches that I described in the last slide. So, and then Dr. Maysoon will help moderate those. We're going to move on to the next step though. And the next step, of course, is introducing the treatment with intravitreal injections and setting expectations. So important. So I go ahead and tell them, once I tell them what they have, I explain that the treatment is going to involve injections into the back of the eye. And the first thing I do is that I acknowledge that fear and anxiety are normal. I also share other patients' first impressions with them. You'll see what I mean on the next slide. I tell them that I do many of these over the course of the day. That helps to take away the feeling that they're alone, that they're the only ones going through that. And I think that helps tremendously. I do not promise a painless experience. I notice a lot of my colleagues tell them, this isn't going to hurt. I'm going to numb you up. It's not going to hurt. I don't like to do that because everyone is different and some patients do feel it no matter what you do for anesthesia. I don't like to promise that because I find that if they do end up having pain or discomfort, you end up breaking a little bit of that trust. But I emphasize that I will pay a lot of attention to anesthesia. I also set expectations that injections are a long-term type of therapy, just like hypertension medications or brushing your teeth. I remind them that the goal is to stabilize visual acuity, but some patients will experience an improvement. And I tell them we're going to start with monthly injections, but hopefully if there's a good response, we'll start to spread them out. I remind them that they're probably going to need these forever. One of the first questions they ask is, how many injections am I going to need? And I never try to quote a number for them because a lot of patients, as we know, will need these for an entire lifetime. And then I tell them that usually patients are able to resume regular activities right away, although it's common to have some irritation on that first day post-injection. I often use my own personal example of my grandmother who went blind from macular degeneration, and I tell them that the injections we have today have revolutionized care. And wet AMD is no longer like a blind sentence the way it was in my grandmother's day and age. So let's walk through this example for the second portion. So I'll start by saying, Mr. Jones, do you know anyone who's receiving treatment for wet AMD? Just to kind of gauge if, what his fears are, what his knowledge is. My neighbor told me he was getting shots for this. Is that what I'm going to need, Dr. Wang? I'm terrified of needles. Any way you can put me to sleep for this? We don't put people to sleep for these shots, but let me reassure you that we're going to numb your eye as best we can. While there's no way to completely numb the eye, the needle is smaller than your hair, and most people say it feels like a mild pinch, kind of like a flu shot. It is totally normal to feel nervous about it, but the most common thing I hear from patients after their first injection is, it wasn't as bad as I thought it would be. And most patients can resume normal activities right away, although it's common to have some irritation on the first day. So a lot of other people are getting these too? Oh yes, we give these shots for all sorts of different conditions. I've probably done at least 10 this morning. You are not alone, Mr. Jones. Well, how many of these am I going to need, doctor? It's hard to say right now since everyone responds differently, but these shots are very much like brushing your teeth. No matter how well you brush today, you will still need to brush again tomorrow. It's important to think about these injections as a type of maintenance therapy. We will start off by injecting every month, and then if your eye responds, we may begin to spread these injections out. So you're saying I'll need these forever? I guess it's worth it if I can get back the vision that I lost. Most patients will need these injections for life in order to preserve the vision that they have. And let me clarify that the goal of these injections is to stabilize the vision you have now. While we can't be sure that you'll recover the vision that you've lost, many patients do have some improvement. But again, keeping the vision you have is our goal. I very much wish these shots were available when my grandmother was diagnosed. So please go ahead and send in your comments to the chat for that section. I'm going to keep moving along in the interest of time. The third is to explain the Yes, I'm sorry. The third is to explain the procedure step by step. And so I like to verbalize exactly what's going to happen. I work with a technician, as some of you may do. They help me anesthetize the eye. So I always tell the patient that if my technician is in there prepping, I reassure them that I'm the one putting the needle in, that takes away some fear. I also prepare them for stinging, which they often feel from the povidone iodine during and after the procedure. I remind them to relax when the speculum is in the eye, and I remind them that there's nothing sharp used for the preparation process. I ask them to hold still and not talk during the injection process. And of course, consenting the patient, I won't spend a lot of time on, but I remind them that the most serious risks are retinal detachment and endophthalmitis, which occur in far less than 1% of injections. But if they do occur, they could cause irreversible vision loss. Other risks include elevated pressure or glaucoma, inflammation in the eye, or bleeding. I always tell them, even though it doesn't make a lot of concern, it doesn't bring a lot of concern to us, I tell them about subconjunctival hemorrhage because some patients, especially those on blood thinners, will have that, and that's what they can actually see. So I remind them that that can happen and that it's not visually threatening. And then I reassure them that I'll do everything I can to make sure that the risks are minimized and ask if they have any questions before I document consent. Mr. Jones, let me explain what's going to happen during the injection process. We do it right here in this room. The technician will be preparing you, but I will be giving the actual shot. First, we lay you back in the chair. We put some numbing drops in your eye. Try not to talk so the bacteria from your mouth doesn't contaminate the eye area. We will then use betadine to clean around the eye. That part might sting a little bit, so please try to bear with it. Then a holder will be used to hold your eyelids open so that you don't have to worry about blinking. Try your best to relax and keep both eyes open. My technician will hold a Q-tip full of numbing medicine on your eyeball. It will feel just like this, and then I'll usually push on the patient's arm or knee so that they can feel that it's pressure but not pain. And I've asked them to use a bit of pressure so that the anesthesia infuses into your eye. Nothing sharp will have touched your eye up to this point. After about 30 seconds, I'll ask you to hold still and you'll feel a tiny pinch as the injection is given, and that's it. We will then wash out your eye and you'll be all done. The whole process only takes a couple minutes. That doesn't sound too bad. I hope I don't move. What could happen if I do? I think you'll be fine. I've given thousands of these and most people are able to hold it still. However, there are risks associated with this procedure, as there are with any procedure, so let me review those with you now. Let me start off by saying that the risk of injections is extremely low, far outweighed by the benefits. The most serious risks include retinal detachment or infection of the eye. These occur in far less than 1% of patients of all injections, but can potentially lead to permanent vision loss. Please be reassured that we have many safety measures in place to mitigate this risk as much as possible. Other things that can happen include bleeding, increased pressure, or inflammation in the eye. It's important to note that occasionally you can get bleeding in the white part of your eye. The type of bleeding is cosmetically undesirable, but actually poses no danger to your vision. What questions can I answer for you? Moving on here, we're going to go to step 4, which is emphasizing long-term therapy and the negative impact of interrupted treatment. So I like to remind patients that these injections are going to be needed long-term. So visual improvements will not always be realized, and remind them that the visual stability is the goal. That is so, so important. I use examples like hypertension drugs. If you're taking blood pressure medications, if you stop them once that the blood pressure is normal, the blood pressure will go back up. And I remind them of that. And then I try, without scaring them necessarily, but to sort of instill a seed of fear, I do like to review the negative impact of treatment interruption and empower the patient. I remind them it's important to come to all of their appointments, that vision may not be able to be recovered if it's lost. Every time they come, they're going to receive an injection, at least based on the way I treat, which is on treat and extend. And then I discuss modifiable risk factors like smoking cessation, AREDS, vitamin supplementation. I think these really empower the patient to let them know that they can take a role in optimizing their outcomes. I remind patients of return precautions for both eyes, considering home monitoring, and explain that the contralateral eye could also convert to a wet form of macular degeneration, and that we're going to be watching them closely for that. And then I clarify the return date and encourage them to schedule on their way out. I find that if you let patients call back, that's when treatment interruption can often occur. And just to recap what we discussed earlier, the goal of treatment is to hold on to the vision you have right now. Without treatment, your vision could continue to get worse and worse, and we want to prevent that from happening with these injections. A lot of times, patients will wonder why they need injections once their vision is stable. Think about blood pressure medications that you take. If you were to stop taking them because your blood pressure was normal, what would happen? Your blood pressure would go up again. It's very much the same concept with these injections. Okay, is there anything I should be doing? Should I eat more leafy vegetables? Eating healthy is never a bad idea. However, I would say that the most impactful thing that you can do is to make sure you come to all of your visits. At every visit, you will receive an injection. Even skipping one injection can be harmful. And what's important to understand is that if you take steps backwards in your treatment, I may not be able to recover the vision that is lost. It may be irreversible. Additionally, I would encourage you to quit smoking, because smoking is very bad for macular degeneration. And I'm happy to connect you with resources to help you quit if you're ready. Lastly, consistently taking the AREDS vitamins will help to protect your left eye from further progression. You might consider setting a daily alarm on your phone to remind yourself. That's helpful to hear. Could my left eye also turn wet? Unfortunately, yes, it could, but I will be watching both eyes very carefully. You may also consider a home monitoring device. I will provide you with a brochure today so that you can look it over and decide if it's something that interests you. Otherwise, I would encourage you to test your eyes with the Amsler grid every day and call me immediately if you see any new blurriness, waviness, or missing spots in your central vision. Great, and I'll return in 4 weeks, you said? Yes, please go ahead and make your appointment with the front desk on your way out. Dr. Maysoon, I only have one more set, so I'll go through that quickly. I know I'm running a couple minutes over time, but then we'll get to the discussion. The fifth is to answer questions and provide take-home resources. So I like to answer any questions from the family or the patient themselves. I think it can be helpful to have them repeat back to you the key takeaways. Patients oftentimes are very overwhelmed. You've given them a lot of information on that first visit. And then I may address social support issues if it's applicable. If they need an accompaniment each time, or transportation, I'll ask them about it to see what we can do to really optimize those types of barriers. I also like to provide them with take-home resources like brochures and printouts. The American Academy of Ophthalmology and the American Society of Retina Specialists have excellent resources that are available for patients, and they can be quite helpful. I'll also provide them samples of AREDS vitamins if it's available, so that the patient can see what they look like when they go to the store to purchase them. And then I give them my contact for my office so that they can notify us if they have any issues post-injection. We covered a lot of information today, Mr. Jones. What questions can I answer for you or your wife? I think I understand everything. I just need to get used to this new routine of coming in every month, I guess. Yes, I know you will adjust, and I'm sure you may have more questions after you digest the information at home. If so, please feel free to reach out to me at the number listed on my business card here, or you can write them down so we can discuss next time. Mrs. Jones, will you be able to come with him for the future visits? Yes, I will make sure he comes. That's great to hear, thank you. I also want to send you home with some pamphlets that you might find helpful. They explain a bit more about wet AMD and the injections used to treat it. And here's a sample of AREDS vitamins. You do not necessarily need to take this particular brand, but make sure the bottle says the word AREDS. Sounds good. We'll stop by the drugstore on the way home. Thank you, Dr. Wang. My pleasure. We'll see you in 1 month. So again, the 5 steps that we've gone through, thanks for bearing with me. I know it was a lot of talking, but I see that there's been activity in the chat box too, which I'm excited for Dr. Maysoon to walk us through. I want to emphasize that I'm sure that there are differences between the way that you may conduct the conversation, just both on an individual level, as well as thinking about the patient population in the Gulf area. I think there could be also cultural differences that make some of what I'm recommending maybe not applicable or not the best way to approach things. So I'm really curious to hear about your thoughts in the discussion. And I'll turn it back to Dr. Maysoon. Thank you.
Thank you, Dr. Wang, for the great presentation. We do have two questions. The first question from Dr. Noor Al-Mansouri. In a busy clinic, how long it will take you to do this kind of consultation and discussion? And do you have to repeat it in every injection visit?
That's a great question. Thank you for that excellent inquiry. You're right. It looks like so much, but I'll tell you that once you get all of the points in and down, it's actually very quick. And as a testament to that, I see about 50 patients in a day. You may see more, you may see less, but that gives you an idea of how quickly I need to move through patients. It's about 6 minutes a patient, with including the injection, including the exam, and including the history taking. And so it's not a lot of time, and you may be overwhelmed to think that you have to cover all of it, but touching on the big points is most important. And then I'll tell you, giving them the brochure and continuing the discussion at future visits is a great idea too, because I think it helps them retain that information. So I would pick biggest points to highlight, but I think that once you adopt this conversation as your own, and Dr. Fortune, please chime in if you have any thoughts, but you can actually get it done in several minutes.
I think, Christina, you did a great job of presenting it in a very thorough manner, but I'm sure that, like you said, you've got your spiel, which may not necessarily be that, but you hit the major points. And I think the important thing is to make sure that you hit those points. You tailor it to each patient, obviously. I think most of us that are experienced clinicians now can tell within 2 minutes of being in the room how apprehensive a patient is or is not going to be about an injection. But I think that it was great, Christina, for you to walk us through how to handle each one of those potential situations.
And to answer the second part of the question, I don't repeat it every injection visit, but I'll highlight points from the conversation, the ones that are very important, and tailor it to the patient. If I see that a patient is starting to get fatigued from these injections, I'll remind them that there can be untoward consequences of stopping and that we are maintaining. So I'll highlight certain things, but really it's the first visit that is, I think, the most resource and labor and time intensive. And don't be overwhelmed. Break it up into several visits. You don't have to cover everything on that first visit.
Thank you, Dr. Wang and Dr. Fortune. We have another question as well from Dr. Ahmed Al-Satrawi. Do ask patient to remove his mask these days. He's referring to the COVID time. Would it change the risk of endophthalmitis? And actually, that was a question in my mind, especially for the patient who maybe not receiving their second or third injection in the COVID, where they've received their first injection prior to COVID. Would that as well change your communication?
Yeah, so the data is mixed on that. It's a really interesting concept and a new problem we haven't had to deal with before this pandemic hit. And the concern, just for those of you less familiar, is that when the patients wear the mask, it's not necessarily sealed tightly across the mid-face, and that you're redirecting their breath, their respiratory secretions up towards the eye. And so the concern was, does that increase the risk of endophthalmitis because of that? And as a result, some people out of that concern have had the patients remove the masks instead. I'll tell you that there have been case reports of endophthalmitis happening more frequently, but large series that have been published recently actually say that it does not seem to cause a substantial increase in the rates of endophthalmitis. And I think we would have, given how many thousands of injections we give on a daily basis, I feel like if there really was a strong relation or association between that, we probably would see it by now after a year and a half. So I actually don't have the patients remove their masks, but I think it's also an acceptable thing to do for that short period of time, especially if no one's talking during that period. Jorge, do you have anything to add to that?
Yeah, no, I think that, like you said, the data initially was mixed on this. And I think, as you said, larger series have borne out that there really isn't an increased risk. What we've done is we will tape the mask down to the cheek in that area. If you really think about how it happens, it's probably not aerosol. It's probably small droplets or large droplets. So it's probably okay to just leave the mask on. But we as a precaution just tape. And I think that as vaccination rates continue to increase, as Christina said, I think, having the mask removed for a while is not a big deal. And in general, Christina, I like what you said. We urge the patients to not speak during the injection because most of the infection actually, comes from either the doctor speaking or the patient speaking. So it's very important to not talk during the injection.
Yep.
There were some recommendation on draping the patient in the era of the COVID as well. I don't know whether that's a practice you do in USA, but we do have this practice here in UAE. Like we do drape the patient if we want to remove the mask.
Mm-hmm. Yeah, we don't typically drape here, Dr. Maysoon, but I know there are certain institutions in the United States that do that. And I'm sure that may change things depending on the way you do it. So.
There were other questions from Dr. Bressan. Do you discuss the option of anti-VEGF? Dr. Bressan, do you mind if I delay this question for later? Because I know this subject will be covered later on as we progress. So let's move on with our, we will not forget you, Dr. Bressan. We'll come back to your question. So let's go for our second agenda topic, which is the discussing the treatment and outcome with the newly diagnosed wet AMD with Dr. Fortune. Dr. Fortune, the floor is yours.
Actually, thank you, Dr. Rao, for asking that question because that is a great segue into my talk. And some of it will be a little bit of overlap with what Dr. Wang presented, but I'll try to keep that to a minimum. I think that I think I commend again Novartis and the American Academy of Ophthalmology and all of you that are involved in this workshop because I think that so many times in our line of work we're just used to seeing data slides and data slides and data slides, and that's very important. And evidence-based medicine certainly has led us to practice better medicine, but the reason that we have not yet been summarily replaced by artificial intelligence is because of the fact that communication with patients is so important. And if we just did everything, based on just looking at OCT and doing treatment outcomes, we'd have very, very poor patient compliance. We'd have patients that didn't really trust us. And that's such a key part to, what we know really is the art of practicing medicine. So much like Christina, I'm going to go through a patient scenario, but we're going to move a little bit further along in the conversation beyond just the talking of how the treatment's going to happen and maybe talking a little bit more about treatment choices, treatment outcomes. And so there'll be a little bit of overlap at the beginning, but you'll see how the conversation progresses. And there's a lot to cover when you first interact with a patient. And you have to discuss, outcomes, dosing and visit schedules, choice of anti-VEGF agents. So it's really a lot to discuss. And I'm going to kind of walk you through a sample scenario of how I do this. Much like Christina, I have a sample scenario here, and we'll try to make it quick. But essentially, I have a patient. Now I've examined her testing, and it appears for the change in your vision in your right eye is now we have wet macular degeneration. And I put this in here kind of as a joke, but patients often do ask us, is this the reason why my eyes always feel wet? Unfortunately, we're retina specialists, but it seems like a lot of the times most of our questions are about dry eye. And so I always say that's an unrelated issue. We can talk about it later. And I go into really explaining what wet macular degeneration is. And I think these conversations about what the disease is are important to have early on because I'm always surprised by patients who I've been seeing or have seen someone else for years and don't really understand their condition. And so I explain to them that wet macular degeneration really refers to the formation of an abnormal blood vessel in your macula. This happens as a part of the natural course of the disease in some patients. And in trying to improve the blood supply to the tissues that are affected by macular degeneration, the body creates new blood vessels underneath the macula. And unfortunately, these blood vessels can leak fluid and blood, which can cause further vision loss if not treated. So patients will inevitably ask, what is the treatment? Glasses, laser, and this is where you drop what my fellows call the injection bomb, which is you have to tell them that they're going to get an injection. And unfortunately, glasses do not address the underlying problem in macular degeneration. In order to stabilize and possibly improve your vision, and I'm going back to what Dr. Wang emphasized, which is you have to set expectations. And as physicians, we always try to sort of under-promise and over-deliver. So you have to let the patient know that the main goal here is stabilization of vision, that we may possibly improve vision, but that the main thing we need to do is stabilize the vision. And that lasers were used in the past, but they did not give us the best results. So that lasers really are not an option. They may go on the internet and read about lasers. They may think that, like everything else in ophthalmology, something's cured by a miraculous laser, but you have to tell them that that laser is not a viable option. And that now we have these medications called anti-VEGF agents that can decrease the leaking from these blood vessels. It's very important. Christina made a great point of saying she uses her grandmother's example about people that used to go blind from this disease. And I think it's very important to emphasize to patients, even though injections are the new normal, they need to realize that up until about a decade ago, having wet macular degeneration really was a sentence for eventual central blindness. And so you have to emphasize that with the medications that we have now, as opposed to the past, most patients keep the vision while a substantial portion of patients gain vision. So the patient then says, well, that's encouraging that there's these medications. Are these drops? And again, you have to tell them, nope, unfortunately, drops don't work. We have to get the medication to the macula in order for it to work, and drops cannot do that. These medications are injected into the eye through a quick and painless procedure. As Christina explained, you may have heard of friends and family getting these, and you'll be surprised how many times patients say, yes, that's right. I know my neighbor gets them, or my in-laws get them. And the other thing I always say is, actually, most of the patients that you saw in the waiting area today are here for injections. It is the most common treatment for many of the diseases that I treat, so that they feel that this isn't, a unique case, that this is really just standard of care. And it gives them a sense of encouragement that most of the folks out in that waiting area are here for injections as well. So I find that really sort of instills confidence in the patient. And then here comes the question, how many of these injections will I need? And I never make any promises. It's difficult to predict this on the first visit. And I reemphasize what the goal of treatment is. The goal of treatment is to get rid of all the fluid and blood and maintain it that way. We need to do that in order to give you the best possible visual result. We will start off by giving an injection every month until there is no more fluid or blood. And this is where I think it's important to maybe show the OCT. They don't need to know everything they're looking at, but you can point out to the areas where there's fluid, where there's blood. If there's a photograph, you can show them the blood. And they understand now what the goal is, and you share that sort of goal with them. And then you tell them, once we've done this, we're going to keep it that way, and we will try our best to do it with the fewest number of injections possible. Okay? It is important to understand that while we may be eventually able to keep you stable with fewer injections, you are going to likely require ongoing treatment. So our goal is stability, possible improvement. You're going to need these injections, but hopefully you won't need that many of them, but you will probably need them indefinitely. Then inevitably the patient says, how will you know when to give me the injections? And that's, again, when I think it's very useful to look at the OCTs with the patients. Again, you don't have to teach them how to read an OCT, but it shows them what you're looking at. It makes them part of that decision-making process. And so, I tell them that scan that you get earlier, that you're going to get every time, it tells us whether there is fluid in the macula or not. And then we will also look at your eye directly or with a photograph to look for bleeding. And this is going to guide our decision on how often we are going to inject. We can talk about it later, but for now, we will inject every month until all the fluid and blood have disappeared. You notice that I sort of redirect there. I don't really get into the specifics about what's going to happen down the road. I really just focus on, for now, you need an injection every month. Let that settle in, and we can talk about how we're going to go later. And then emphasize that the most important thing to remember is that without treatment, you will most certainly lose vision. You're not trying to be pessimistic, but you need to be realistic with the patient about the importance of their treatment compliance. And then somebody asked this earlier, actually, do you have friends? Somebody said, how do you talk to them about different agents? They may have known that there's different agents out there. And I say that is a good question. There are 4 different types of these medications that are used currently. They are all basically similar and work and are administered in the same way. All 4 of them are very good. They have shown good results in a majority of patients. And in some patients, some of the medications may work better and allow us to inject less frequently. And we may choose to switch you from one type to another depending on how you respond. So just a few overviews. Stick to the basics and keep those basic. There's a lot of information to convey at the time of the initial diagnosis. The patient is likely nervous and overwhelmed and is not going to absorb all that you are saying. So just keep it basic, convey the key points, and get specific only in response to specific questions. Discussing outcomes. So I firmly believe that this is not the time to quote statistics and clinical trial data. This is really complex info, even for us retina specialists, let alone a patient with no medical training who's overwhelmed by the new diagnosis. And patients if you give patients data, they don't understand averages. If you quote specific numbers, they may be unduly encouraged or discouraged with their individual results. So if you tell somebody X number of patients only need X number of injections, they're going to stick to that. They don't understand that that's the average over hundreds of thousands of patients. They're going to think that you're saying that's how many injections they're going to need. And by setting, false expectations, they may be discouraged. And again, stability is the goal. You need to emphasize that the main goal is stability and that improvement is very possible, but not guaranteed. And again, emphasize the fact that without treatment, there's no possibility of improvement and near certain worsening. As I said before, I often remind patients that this was the case only a decade ago. So again, you don't want to be overly pessimistic, but they need to understand the reality of their situation. So discussing treatment strategies. Don't get too far ahead of yourself. At the initial encounter is not the time to get into PRN versus treat and extend. The patient will understand this better later on as they become more accustomed to the treatment. Convey the importance of intensive treatment at first for the best outcomes, with the hope that they will have decreased treatment burden later. Convey the chronicity of this disease and the need for long-term treatment. And so I always say this and teach this to my fellows, is disappointment comes when expectations do not meet reality. So be thorough about all the possibilities, but don't get bogged down in the details. Don't paint yourself into a corner with specifics that the patient is going to stick to and going to hold you to. Be realistically optimistic. Patients need to feel encouraged, but not set up for disappointment if, for example, they remain stable, but don't significantly gain vision or worsen. And remind patients that worsening is a possibility. A smaller possibility, but it is a possibility. So we'll try to get through this quickly. I'm still going to recommend an injection. So this is at the follow-up visit. I say, I'm still going to recommend an injection because I want to maintain the gains we have made and give this eye a chance to possibly improve by maintaining fluid-free the macula. Because the scan looks so good today, what I am recommending is that we start spreading the injections out. So rather than see you back in 4 weeks, I will see you back in 6 weeks. If the scan looks good then, we will inject you again and we will spread the interval out to 8 weeks, and so on, as long as the scan has no fluid and there is no bleeding. If there is ever fluid or bleeding, then we will shorten the interval or consider using another agent. And then they'll always say, well, can't we just skip it today and give it when the scan looks worse? And I say, the problem with that strategy, we could do that, but understand that the problem with that strategy is that it's going to require more frequent visits to monitor the scans. Some studies have shown that as-needed treatment does not yield the visual results that are as good as scheduled treatment. And I know that these injections aren't pleasant, but they are the only treatment we have to prevent vision loss. Would it be okay to consult my family before making a decision? Absolutely. And if you'd like, I'd be happy to answer any questions that they have. Always give the patient a chance to think about the treatment. So now we're moving farther along. Now, Ms. Smith, you've had 2 injections over the last 2 months and your scan shows no fluid and there's no blood in the macula. This is great news. You've had a good response. And inevitably, you will seem very encouraged, but the patient will say, I feel like my vision is not getting much better though. And I'll acknowledge that. I'll say, look, you're not wrong. The vision has only improved 1 line on the chart. But remember that this is still an extremely positive outcome because we have been able to control the leaking and the bleeding, which is the most important step in keeping you stable. There may be room for visual improvement as the vision sometimes can lag behind improvements in anatomy. So do I not need an injection today if you think it looks so good? So you explain to them that they still need an injection, and now they've made it out to 12 weeks, and why is my vision getting worse? And this is where I think that you always need to explain that there's no such thing as wet or dry. There's always dry. And I make it a point to always discuss this with my patients. I don't get so focused in on treating their wet that I forget to remind them that there's always dry macular degeneration. Because as we all know, once we get the wet under control, inevitably what causes the gradual vision decline is the dry macular degeneration. And so I always explain to them that the dry macular degeneration is happening in the background and that we don't have a cure for macular degeneration, but that there is hope and other ways we can help with magnifiers and reading aids. And so I'll briefly sum up here that shared decision-making is important. Patients don't need to be experts in their condition, but they need to know about their condition. And the more trust you instill in a patient, you'll find actually that the less in-depth conversations you actually have to have with them. So it's worth having these discussions early on because by instilling trust in the patient, it will make your life easier going forward. And, you know, I won't read through all this, but the most important part is to engage these patients, make them feel like they are part of the decision-making process, answer the questions they may have, don't get into specifics, but try to answer questions generally, be realistically optimistic. Again, don't overpromise, but, you know, explain to them the reality of their situation, that this is going to require ongoing treatment, but that the outcomes that are visible are very, very good in most patients. And so with that, I'll open it up for questions.
Thank you, Dr. Fortune, for your presentation. We have a question from Dr. Rao, which he asked earlier, is regarding, do you discuss the option of anti-VEGF medication and possibility of switching in the event of the treatment failure?
Yeah, so, you know, I try to introduce that very briefly early on, and I say we can talk about that later. I always tell them that all 4 agents are basically the same. We're going to start with agent X for whatever reason. You know, it may be that, for example, in your clinic, you always start with Avastin because you don't have samples available or because insurance doesn't verify. And so they need to know that whatever agent you're giving them is really still a very good choice. And I bring up the fact that we may switch to something else down the road, but I bring it back to the fact that let's not have that conversation just yet. Let's focus on intensive treatment right now to get things stabilized. And I don't know, Christina, when you bring that up in a conversation with your patients.
Yeah, I will, you know, believe it or not, I will not spend that much time on it. I find that most patients trust me enough to make that decision, that we have this body of scientific knowledge to really pick out on those subtleties and make that best decision for the patients. For example, for patients who have predominant pigment epithelial detachments, I personally lean towards branded agents, just that my personal preference. They don't need to know the intricacies of that in my decision making. There was a great question by Dr. I think it was Rao, who asked about specific agents if a patient requested that. I think that, I don't know, Dr. Fortune, I'd be curious to hear your thoughts, but I find that to be very seldom. But if a patient comes to me and says that they absolutely want ranibizumab or brolucizumab or aflibercept or whatever it is, generally, I try to respect that request because, again, like you said earlier, they are very, very similar.
Yeah, I agree. I think that, as I said, I only get into specifics if the patient wants to know specifics. And it's not out of any sort of attempt to hide information from the patient. But as I said, I think that they're overwhelmed as it is on some of these initial visits. So even if you get into it, it's not really, you know, going to do them any good. They're going to fixate on that and miss some of the more basic points. And so I agree. If somebody wants a branded agent, or some of these patients are very well read, very well educated, and they come in with very specific questions, I'll try to answer them to the best of my ability and respect their choice for whatever agent they may want. But I've always emphasized that any of the agents we have are very, very good.
I think there were another question from Dr. Noor Al-Mansouri regarding did your practice change during the COVID-19 era, especially in the regimen of the treatment? Do you use more treat and extend more than what would you normally do?
I think for the most part, I treat and extend in my patients. Some of the sort of exceptions to that rule is if I have a functionally monocular patient, I may treat and extend, but limit their extension interval and then just, keep them at a fixed interval where I just inject them every 8 weeks. During the COVID era, I will say that we stopped some of our treat and extend. In other words, we left them at the current interval that they were at the height of the pandemic so that we could just bring them in and just inject. We weren't getting a lot of OCTs in those patients. But for the most part, we've gone back to just straight treat and extend where I'm imaging the patient at every visit and extending if possible.
In that same alignment with the treat and extend regimen, I don't know whether you share the same culture as in here. Like when we do explain for the patient that we are, especially if you strategize your treatment around the fluid and you share the OCT with the patient, then you bring them to inject them on the treat and extend, they will tell you, oh, but there is no fluid. Why are you injecting me? Mm-hmm. I don't know whether you have the same concern as well, or do you get the same concern from the patient as well?
Yeah, I included
how do you communicate that effectively?
Yeah, I included that in my sample communication because it does happen. You're right. So, what I tell them is, PRN treatment, right, requires more visits. So oftentimes if you explain to them, it's okay, we don't have to inject you today, but I have to see you back in 4 weeks, or I can give you an injection and you won't have to come back for 10 weeks. They sort of get that. And then, without getting too much into detail, I tell them that yes, PRN treatments are more visits, and there's some evidence to suggest that unless they're seen monthly, that PRN treatment may result in worse visual outcomes. And so usually they don't like the needle, but they like less visits. And so, that's one way to get around that. And I don't know, Christina, your thoughts on that?
Yeah, no, it's so interesting. And that's why, by the way, Jorge, you touched on so many great points. I was like nodding away during your talk because I do so many of those same little pearls that you do. And I think that's why it's really important from the get-go to explain, especially if you do treat and extend for 99% of your patients like me, to explain that every single visit they're going to get an injection. Just tell them that off the bat, because that is inevitably a question that's going to come up, where they say, well, I'm still dry, so why are you injecting me today? This is not doing anything. And it goes back to the point that Dr. Fortune also made about re-emphasizing the fact that we are working to maintain vision, because oftentimes you'll see patients be very compliant on that sharp part of the curve when they're improving and experiencing visual gains. But once they get to that plateau level, they forget that it takes injections to maintain them on that plateau section. So it was a great presentation.
So thank you, Dr. Fortune. We will move to the third topic in our agenda today, which is intravitreal injection, common patient concerns and challenges, and how to overcome them. This will be presented by Dr. Wang. Dr. Wang, the floor is yours.
Thank you very much. All right, so we're going to continue building on that excellent talk by Dr. Fortune. And this really is going to focus now on some common patient concerns and challenges. I bet you all of us have encountered all of these challenges that I'm going to bring up today in this talk here. And I want to show you some ways of how I've been able to overcome them. I would absolutely love your ideas. Thank you for your questions and comments. Please keep them coming in the chat, and I'll try to follow along as we go. So the objectives here are to really understand the patient side concerns and the challenges that can result in undertreatment with intravitreal injections and subsequent suboptimal visual acuity outcomes, and to also recognize the common barriers to patient compliance with intravitreal injections and learn how to address them. Let's take a look here at this slide. This is from Rick Spade's talk at the subspecialty day in retina at the American Academy of Ophthalmology just a couple of years ago. He did this meta-analysis where he looked at a lot of different studies that treated patients on a treat and extend, a PRN, or a fixed monthly basis, and saw their visual acuity changes at the 1-year time point. And essentially what you're looking at here is that we know that more injections equals higher visual acuity gains, right? However, in the real world, we know that patients unfortunately don't get that many injections. You can see here on this graph that patients who are treated on a fixed monthly basis in general have greater visual acuity gains at the 1 year time point than people on variable or PRN dosing regimens. But we know that there's a mismatch between what we see in the large clinical trials like Anchor and Marina and the VIEW studies. Those patients who are getting injected monthly with anti-VEGF got between 7 and over 11 letters over the course of a year. I mean, that's so amazing compared to where we came from, right? Pre-2005, 2006. But in the real world, even though we have the same drugs in our hands, if you look across lots of different large studies, such as AURA or some of the database studies, you can see patients aren't getting that many injections. They may get 4, 5, 6 injections a year. And as a result, they only gain 2 to 3 letters over the course of a year instead. Here's another really large study from the United States that looked over at over 100,000 eyes that were receiving anti-VEGF for neovascular AMD. And you can see here, this was even more shocking, that over the course of 4 years here, you can see that there was actually a decline in the visual acuity over that time. The first year, they seemed to gain letters, although it was only 1.1 in this study. But over years 2, 3, and 4, there was actually a loss of visual acuity. So you ended up gaining and then losing all of that and then some. The mean injection number of injections over the course of a year in this study was between 6 and 7. So it points to the fact that, A, there might be a component of undertreatment, B, there might be a component of disease progression as well. But undertreatment is definitely one part of this. And there's many risk factors for non-compliance. I'm sure you see this in the Gulf region too, that patients can get lost to follow-up. There have been lots of factors that have been identified, such as older age, a non-white race. In the United States, a regional adjusted gross income of less than 50,000 USDs, living a farther distance away from the clinic, and even patients getting unilateral injections. These things seem to contribute to a greater risk of loss to follow-up. And I want to focus on a couple of those things right here. That older age, number one, is associated with undertreatment. So if you look at the graph on the left here, which comes from a study by Tom Chula, which looked at almost 50,000 eyes published in Ophthalmology Retina just last year, you can see that the older that the patients are, which is on the y-axis, the fewer number of injections they get over the first year. And there probably is a number of different reasons why we're seeing that type of trend, but you can imagine that older patients may have a bigger struggle with getting someone to bring them to the clinic, a bigger struggle with transportation, more comorbidities, etc. There can be lots of reasons behind that. And then, to emphasize the point that I made earlier, look at the pie chart to the right. The compliance with the first 3 injections tends to be very good. Blue is what's compliant, orange is non-compliant. So when patients are on that steep rise where they're experiencing and enjoying those visual acuity gains, they tend to be more excited to come in. After about a year, you can see that that drops significantly, where only 2/3 are compliant now in this study from Turkey. And that's partly due to injection fatigue. The undertreatment we're going to focus on is on the patient side, but remember there are also provider side factors. For example, when I'm out of the office, sometimes my patients have to go an extra week. It's not ideal, but it's the real world stumbling blocks that we come across. Holidays, same type of thing. We also may tend to be less aggressive sometimes than perhaps we ought to. But I really want to focus on patient side factors, including transportation, mobility, need for accompaniment, finances, fear, lack of understanding. Of course, they also often have caretaker responsibilities. Maybe they're taking care of their sick husband at home, or the comorbidities themselves. Maybe they have, kidney issues that they have to see their doctor for, diabetes, things like that. I want to take a look at these 5 that I've highlighted in red here. So just to kind of draw your attention to some shocking stats. Do you know that the average time, at least in the United States, that a neovascular AMD patient spends for an injection, if you include the appointment preparation, their travel time, their wait time, and then post-appointment recovery, it ends up being 11.7 hours, which is baffling because you think to yourself, well, it only takes 2 minutes for me to inject into their eye, not for the patient. And that's something really important to remember. Additionally, the greater travel distance, as I mentioned, is a risk factor for loss to follow-up or non-compliance. Do you know that in the United States, about 72% of patients with neovascular AMD reported that they needed to be brought to their appointments by somebody else. And that somebody else is often a neighbor or a friend or maybe even a child. And that son or daughter may also have to take time away from work in order to bring them. So it's not a small feat. The financial costs we know are great with not just the injections, but the actual visits and examinations and testing. I want to talk about fear for a moment. I think this is a big driver. So psychological anxiety associated with injections has been frequently reported. And if you look at some studies like the one I showed you in this bar graph to the right, that is the leading cause of what patients are concerned of and why they may not come back is fear. No one likes getting a needle stuck in their eye. And finally, lack of understanding. 40 to 80% of medical information provided by healthcare practitioners is immediately forgotten, which is kind of sad, but it probably is true when you think about it. It's a lot of information that sounds very familiar to us. These are not familiar things to the patient. And the greater the amount of information presented, the lower the proportion that is correctly recalled. And remember that half of the information that they actually do take home with them may be incorrect. They may interpret it differently or remember it differently. So these are all barriers. So what are potential ways to address these factors? Well, you can, consider things like injection-only clinics to streamline operations. That may reduce the amount of time that the patient needs to spend in your clinics. You might consider switching to a longer durability agent so the patient doesn't have to come as frequently. Mobile injection clinics are something that is not that common yet, but may become more common over the years, where we actually will drive a bus or a trailer, as you can see at the bottom right, to different sites around the community, and patients can get their injections there, just like what we did with COVID vaccines, something similar to that. And then in-home and remote monitoring, I think, can maybe potentially play a big role in reducing the time and transportation costs, because maybe patients can be checking their own OCT at home in the future, and they might not need to come in, and maybe we can tailor our treatment regimens differently and personalize them more once we have that data on a more frequent basis. The need for accompaniment. So I consider scheduling flexibility for my patients, if I can, on days that can help them or times that allow them to come at various points of the day. I try to do that for patients so that their compliance with appointments can be better. I also will help staff appointments with different divisions and departments. In the building I work at Baylor, there's also a dermatologist in there. There's orthopedics in there. And so if patients happen to have appointments with those divisions, we'll try to line up the injection on the same day so they only have to come once. And then with regards to financial costs, I don't know how it is in the UAE and the Gulf, but exploring patient assistance plans, which we have here, sometimes can be helpful. And then we also have payment plans for the patients themselves through our institution. What about fear? Well, sometimes if patients really are feeling a lot of discomfort during the injections, I may switch my form of anesthesia. I generally use topical. I soak a Q-tip with anesthetic and put it on the eye, but there's a handful of patients who I do subconjunctival injections for instead because it works better for them. So I try to work with them to minimize that discomfort. Letting the anesthesia sit long enough is also really important. I've started doing the stress ball thing where I have a stress ball that I give to patients and let them squeeze that during the injection. I don't know if it helps, but for some patients, it kind of takes their mind away from the actual injection itself. And then I try to verbalize the process. I try to walk them through what I'm doing during the injection process so that they feel less fear. And then finally, lack of understanding, right? So Dr. Fortuna and I talked about re-emphasizing some of the really important points to the patient and again, but also I think providing them with things that they can take home is really, really effective sometimes. So the handouts that I was talking to you about, this is from the ASRS, and these are available actually for free on the ASRS website. If you go to the patient tab, you can really nicely print some of these pages out and actually just hand them to the patient to take home. That way, when they're in a calmer state of mind at home, they can take their time and read it and help retain some of that information. Bringing in family or support network, I mentioned in my first talk, is really helpful when counseling the patient so that they can help have someone kind of have two sets of ears and retain that information better. And finally, repeat. So you don't have to get it all in the first visit. I reemphasize a lot of these points, their second visit, their third visit, their fourth visit, especially the point about the goal being visual stability rather than improvement. I want to go through some patient scenarios now, and I'm going to try to follow along in the chat, although sometimes it can be hard in presenter mode. But I'd love to hear sort of what you would do for these scenarios. So if you could type in the chat box some of your input, I would really appreciate that. So these are real patients of mine, and I want to show you how I address some of the challenges here. But let's start off with this one. This is an 84-year-old female with wet AMD in her left eye being treated with anti-VEGF. And the challenges that I noticed were that during her first injection, she was shaking. Her whole body was shaking because she was so fearful during that first injection. She did okay. And then after her second injection, unfortunately, she had a lot of pain in her eye for days. I don't know if it was just the betadine wasn't washed out enough or what it was, but she had a lot of pain after that second one. She needs her son to bring her to her appointments. Her son works, so he also has to take off work for that. And then she was lost to follow up for 3 months after her first 2 injections. If you could type in, things that you would do, I'm going to share with you what I did here in this case, and you let me know if you have better ideas or if you would have done something differently. So the patient returned finally 3 months later, had worsened vision, worsened fluid. Some of the solutions that have worked for her are, I have my tech hold her hand now during the injection process. That's really helped quell her anxiety. It sounds like something so simple, but my tech is there anyway, and it really helps her. I also do extra irrigations post-injection. I think some people are just more sensitive to the betadine, and that's helped minimize the discomfort. I'll often tell her to use artificial tears as well. I allow her to schedule as the last appointment slot of the day to minimize impact on her son's work schedule. So even though I only technically have up to 4 o'clock, I never ever finish at 4 o'clock, I'm embarrassed to say. So I tell him it's okay to come at 5 o'clock, that I'll be waiting for them. And that's really helped her son also with his job and his obligations. And I counseled her on the importance of injection compliance, of course, reminding her that taking off 3 months is not good and can lead to irreversible vision loss. The outcome here is that the patient has experienced a lot less anxiety and discomfort since then. She hasn't missed a visit since that. Dr. Rao said that he likes to play some soothing instrumental music in the injection room. Oh, I really like that idea. Jorge, do you do that? Music in the room?
Yeah. It's interesting because that brings up another point which I wanted to make. Our technicians who actually, like you, prep the patients and oftentimes will interact with the patient much more closely than we will, because in a busy clinic, we're just coming in to give the injection oftentimes. All these tips and tricks that we all have, it's important to share this with your support staff and also to listen to your support staff about each patient's sort of fears and attitudes, because they'll oftentimes know these things better than you will. And so actually we started playing music because we found that a lot of our technicians told us that they found that it helped the patient. So really it is a team effort, and I can't emphasize enough how important it is to involve your support staff in taking care of these patients. And a lot of this stuff that we're discussing is oftentimes better conveyed by your support staff than by yourself. So and we certainly learn from our support staff a lot.
Absolutely, I completely agree, and I really like that idea. I think that's something I might start trying, Dr. Rao. So thanks for the suggestion. Dr. Noura Al-Mansouri also said that she would ask her to do some relaxing breathing techniques. And I think that's such a good idea as well. And it makes me think of one patient who I did pan-retinal photocoagulation for proliferative diabetic retinopathy a few months ago. He was wearing the set of headphones and I was asking him what he was listening to. And it was some sort of meditative counseling or coaching to guide breathing. And he said it really helped him make it through a procedure that can be also uncomfortable. So I think these are great suggestions. Thank you so much. Let's move on to this next scenario, and please keep your suggestions coming in the chat. This is a 74-year-old female patient of mine with wet macular degeneration in both eyes, being treated with anti-VEGF. She doesn't drive, unfortunately, so she requires a neighbor or friend. She's a widow. She relies on a neighbor or friend to bring her every 2 weeks since she does not want same-day bilateral injections. So imagine having to come to your doctor every 2 weeks. I mean, it's a lot. Her vision did improve from 20/60 to 20/30 after the first 6 injections in both eyes. But after that, she did not return at the recommended intervals. She also lives on a fixed income like a lot of our senior citizen patients do, and was worried about associated costs. What would you do in this situation? I'll share with you what I did while those chat messages are coming. So the patient ended up coming 10 weeks after her last injection, despite being asked to return in 6 weeks, 4 weeks late. And we all know that 4 weeks can make a world of difference when it comes to their visual prognosis. So this is what I did for this patient. I offered same-day bilateral injections, even though she declined them the first time I met her. I said, you know what, we could reduce the number of visits that you've got in half. And I used different lots to minimize the risk of, God forbid that there's some sort of compounding issue or contaminant in some of the vials. I like to take that precaution. So I choose different lots for her. I counseled her regarding the importance of injection compliance, and I gave her reading material to take home. I also enrolled her into a patient assistance program that reduces her copay. And the outcome for that has been that this patient has been really satisfied with bilateral injections and has demonstrated excellent compliance since. It's funny, I used to myself rarely offer same-day bilateral injections because I thought it was a lot for the patient to take, and the trivial infection risk I was worried about. I do it more and more because of compliance issues. And I find that actually patients are very tolerant of it. I treat one eye, I rinse it out completely, and then I go to the other eye and do it. And they really do very well. I don't know. Jorge, do you like same-day bilaterals?
Yeah, I do. I push it actually because, again, as I said before, I think patients are scared of the needle, but actually what they're more not scared of, but what they worry about more, what causes stress is these frequent visits. And so if I can tell them that, I can minimize the number of visits, oftentimes they'll go for it. And I certainly have a large number of patients that still don't want bilateral injections. What I try to do is make that second visit as short as possible. So in other words, if they're getting injected within 2 weeks or even within a week, I won't repeat the OCT at the next visit. They'll just come in for an injection only visit where we really just vision pressure, no dilation, just a quick injection, so that hopefully that minimizes some of the burden on their social support networks.
Yeah, I completely agree. I think those are great suggestions. And Dr. Rao, thank you for that. I don't know that singer, but I will look that up and take a look. And then Dr. Nouram Al-Mansouri also agreed that same-day bilateral injections may be a good approach. So thank you for that affirmation in the way I approach this. She asked, would social workers help to sort out social and cost issues with those patients? I very much wish that we had social workers in our institution. I know Baskin-Palmer has something similar to that. When I was in fellowship, we had people to help us with that aspect, but at Baylor, we actually do not. Jorge, comments on that? I mean, that would be really nice.
Yeah, I mean, I think it's tough unless you work in a hospital setting where perhaps you share a social work department. But certainly to the degree that you can, as your practice allows, have a sort of go-to individual that can help patients with things such as payment and patient assistance programs and all that, so that they, these patients are going to be coming to your office for a long time. So if they can develop a relationship with somebody, particularly somebody that is good at dealing with patients, it actually will help your practice a lot, because you don't want to, and it's hard for you because you don't know the specifics sometimes, to get bogged down into those conversations.
Yeah.
And so it's nice to be able to pass that off to somebody who you trust, who the patient will eventually trust, to deal with those things. So in the absence of, true social workers, identifying somebody in your practice that can play that role, I think is very important.
Yeah, thanks for that comment. And Dr. Maysoon, I just have two more quick scenarios. I didn't want to, I think this is such great discussion that I'm going to just kind of segue into the discussion section briefly. So we'll be wrapping up soon. The third scenario is a 78-year-old male with wet AMD in his left eye with chronic back issues being treated with anti-VEGF. Challenges for this patient: he improved from 2100 to 2030. So he was one of those that we detected early and really got an awesome visual acuity gain following his loading injections. But he didn't improve beyond 2030 between injection number 4 to injection number 8. And he told me, I remember, after the third injection, I don't know why I need these anymore. The shots have stopped working. And it's funny because you're here clapping, thinking, wow, amazing that you've gained so many lines. And that becomes their new normal, and their expectations get higher. He also has many doctor's appointments between me and his orthopedic surgeon, who I told you is in the same building. And he lives 1 hour away. And with Houston traffic, those of you who have visited Houston, it is no small feat. With traffic, it can really be quite a struggle in getting to the clinic. I'd love to hear what you do. In the Gulf, I don't know for sure, but I assume that you see patients also from lots of areas around that region, and some of them may have to come from miles and miles away. So I'm sure this challenge is a common one universally. Let me share with you here what I did. So this patient is someone at risk for loss to follow-up. You can tell right away when they start asking why they need them, when they start plateauing, when they live far away, you just know this patient is at risk. And so what I did was explain the fact that injections are a type of maintenance therapy and that you risk irreversible vision loss without them. I really try to emphasize that every single visit, hoping that it sticks and kind of is more embraced by him each time. I also showed him his initial OCT. I pull up the OCT from the very, very first visit and showed him the most recent OCT to demonstrate that there's clearly been an improvement. They don't have to know how to read the OCTs, like Dr. Fortune said, but even patients can appreciate that there's no more large black space in the subretinal space, right? And they can appreciate the regaining of the foveal contour. And so I try to show them that because a lot of times we get into a very microscopic mode where we're looking between each visit, last visit, this visit, last visit, this visit, and you may not notice large changes anymore. And it's important to go back to that initial OCT to really remind them how far they've come and that we don't want to lose that ground that we've gained. I additionally aligned his orthopedic visits with his injection visits. It took a little bit of work on part of my staff, but we were able to get him so at least he was seeing his orthopedist the same day. And that's really helped him because that way he can come and feel like he's getting 2 doctors for that trip instead of just 1, especially when he's getting injected still pretty frequently. This is a great patient that I caught before we had issues, right? I noticed that he was at risk to follow up. I try to address those challenges right away, and he continues to do well. He's still 20/30. I don't think with a small degree of atrophy that he has, he's going to get beyond that, but he's not having compliance issues. So I would say this is maybe a near miss. Let me take a look here at Dr. Noura Al-Mansouri said that I would keep showing them their pre and post injection OCTs. It's a great tool to remind them about their progression improvement. So thank you very much. I completely agree. And we need to listen very well to verbal and nonverbal language. And I 100% agree with that you have to read between the lines sometimes with what the patients are telling you and even their behavior. Sometimes they come in and they're maybe upset or they're just very solemn and somber. And those can be early warning signs for someone who's not going to be coming back. So it's better to intervene when you can before that happens. And finally, we'll finish off with this last scenario to wrap it up. This is an 82-year-old female with wet AMD in her right eye, treated with anti-VEGF. Her challenges are that she has mild hearing loss, like many patients of her age. She always comes alone. She was very compliant initially, but then was lost to follow-up for 5 months and was very nervous about coming during the COVID-19 pandemic, which I completely understand, despite safety measures taken by our clinic and staff members. So would love to hear your thoughts on this. Please chime in through the chat box. But this is what we did. So she ended up getting lost to follow-up for 5 months. And unfortunately, she returned with a dense subretinal hemorrhage. And her vision went from 20/30 to counting fingers at 3 feet. Very, very devastating. So this is a complete opposite situation of the last patient, right? Where we've now gotten to a point where we know there's probably going to be irreversible vision loss. So what I did here was I emphasized to her from the beginning that we might not be able to recover her visual acuity in the right eye. I think it's important to it sounds pessimistic, but it's important to tell them that so they know why we're going in the direction we're going to go. But I reminded her that we would try to start an intense injection regimen. I asked her to start bringing a family member with her to her appointments. I wondered with the mild hearing loss whether she was truly hearing all of the things that I was telling her. You can tell I'm also a fast talker. I understand that. And I really try to slow down sometimes and speak up. I'm a loud talker, but I'm a fast talker. And so slowing that down for a patient sometimes is very important because I recognize they don't use these words commonly. They might not understand every word that I'm saying. I reviewed return precautions for her left eye. I think in this patient who's now effectively monocular, very important to remind her what to come for if her left eye starts being symptomatic. And I streamlined her visits as much as possible. We bleach down the rooms still to this day in between patients now as a result of the COVID pandemic. But for patients who are especially nervous, I will actually clean in front of them myself when I sit them down. I think that gives them some comfort in knowing that what they're touching is completely hygienic and disinfected. Not such great outcomes in her, obviously, as we would expect. Her visual acuity has improved slightly in the red eye, but she's still undergoing monthly treatment. She has had improved compliance and understanding of disease. So not as happy of a case as some of the other ones I've shared, but I think we have all seen this, unfortunately. Dr. Luisa Sater, sorry if I'm pronouncing incorrectly, but asked a very important question. Do you ever call patients that are not showing up? And I am definitely caught red-handed here, because I'll tell you that the missed appointment systems, at least in the United States, and I'd love to hear from you on the call as well, especially Dr. Luisa. Here in the United States, we don't have great systems for patients who don't show. We have great reminder systems. So patients are reminded like 5 times before their appointment that their appointment is coming up. But if they don't show, our systems are imperfect. So yes, we try our best to contact patients and remind them to come. But I'll tell you, I've definitely had patients fall through the cracks. Would love to hear your thoughts on that. Dr. Fortune, if you have any thoughts on this issue, I think it is a big problem.
Yeah, I mean, I think you hit it right on the head that in an ideal world, we'd like to do it, and we try our best. Sometimes these patients do fall for the cracks. I do make it a point early on in the course of treatment to try if a patient has missed their appointment, because I think that, not only is it good for the patient's outcome, but it builds that trust. I think sometimes, and it goes with the showing the patient the OCT, it goes with this concept of shared decision making, where they see that you are not just walking in and saying, hey, you need an injection. Sometimes patients can feel like you're just doing this because the more injections you give, the more money you make. And when you call them and you show some sort of empathy and say, hey, I'm really concerned about your vision here, I think it establishes that trust. And I think the comment that was made earlier about the nonverbal cues is so important. I think it's hard to learn as trainees sometimes because we're rotating between services, but Christina, and all the doctors on here know that you get to know these patients very well, and you can tell just from walking in a room or from that patient's behavior that day, who's going to be at risk for noncompliance. And those are the people you need to stop and take a little bit of extra time and kind of re-explain and show that you are invested in this decision-making process with them. So,
yeah. Totally agree. So just really quickly, I won't read these in detail because we've covered this in depth and we're a little bit over time, but in summary, patients may face multiple challenges that impede compliance with intravitreal injection therapy. And those are the ones listed out that we talked about. Acknowledging and addressing these can optimize visual outcomes and also strengthen that provider-patient relationship, as Jorge just said. And remember, I'm really excited. I'm sure we're all very excited about these longer durability agents that are coming down the pipeline, and novel service provision approaches like the mobile clinic and in-home monitoring. I think these will really revolutionize our field in the way that we provide care in the realm of neovascular AMD and a lot of our other retinal diseases as well, that hopefully will alleviate some of these issues. So thank you very much. And I'm going to get out of screen share here.
Thank you, Dr. Wang. Before we move to the last presentation, I just want to get your experience, in the era of COVID, which pushed us to do lots of things outside the box, like the telemedicine. I don't know what is your experience with using telemedicine or monitoring devices in, reducing sparing patient visit to come to the hospital, or at least improving the monitoring at home. Do you have any experience with any ophthalmology devices or monitoring home devices? I know that you've mentioned something in your presentation.
Yeah. So the only one that I'm aware of that's FDA approved in the United States is the 4C Home from Notel. And I do have a handful of patients on that. That's not a home OCT. What that is a monitoring device that allows patients to kind of put their head in this little machine a couple times a week, and it looks for metamorphopsia and where there could be small scotomas, kind of acts like a super Amsler grid, if you will. And it's nice because it notifies me if there's any abnormality on their testing. And I'll tell you, I just had a patient that I detected an early conversion with when she was completely asymptomatic. I just had that in the past couple of months. So it does work when it's done. The problem is the patients still have to be compliant with their testing on that machine, and that can be a hard feat sometimes. And not everyone can afford that. There is an additional copay from, that's required to do that. But the in-home OCT, I think, is something that will be even better than that, because that's what we are using to guide our treatment regimens these days. That is not available yet. It's still in the final stages of investigation. But I hope that in the next couple, 3-5 years, that we will start having that. And I do think that our treatment paradigms may shift a little bit after that is out.
Thank you, Dr. Wang. So we'll be moving now to the last talk in this workshop tonight with the management scenarios on patient with persistent fluid in wet AMD, the patient with treatment fatigue in wet AMD. Dr. Fortune, the floor is yours.
Thank you. Bear with me 1 second. Here we go. Great. Can everybody hear my audio? I was concerned that the last talk my audio wasn't on, but everybody can hear me?
Yes, loud and clear.
Perfect. Great.
Yes.
So we'll try to make this session interactive as well. I was asked by the organizers to talk about these two potential treatment scenarios, which are not uncommon, and which kind of play into, at least with the treatment fatigue scenario, into what Dr. Wang was talking about with patient compliance. Given that a lot of these patients obviously require, chronic therapy, intensive therapy, and so we run into this issue of treatment fatigue. But let's start off with at least this scenario, which is, persistent fluid and poor visual acuity, and it gets a little bit more. We'll talk about how you deal with discussing this with the patient, but we can talk a little bit more too about sort of the nitty gritty of the science and the medical decision making. Because obviously this is a patient scenario that we deal with often, and I know somebody earlier was asking about how do you discuss switching with patients. So this is a patient of mine who had wet AMD and had initial improvement in their fluid after initiating therapy, but now has persistent subretinal fluid despite monthly dosing. In this case, with intravitreal aflibercept. The patient's vision has improved mildly from 2100 to 2080. And the patient now is sort of becoming frustrated because they're coming in every month and they state, "Doctor, I'm not noticing any improvement and I'm still having difficulty reading," which is very important to them. So, I'd be interested again, as Christina was, and perhaps Christina, you can help me monitor the chat since I can't see it very well from the presenter view. But I'd be interested to see what everybody would discuss with this patient. And I think that the choices here are to consider switching to a different agent, given the patient's lack of anatomical improvement in the setting of a poor visual acuity. And at least for me, the switch from aflibercept really becomes to sort of the most recent agent, and we won't get too far into the weeds about some of the issues that have been discussed with brolucizumab. But I think that regardless of whether this patient was on aflibercept and they were switched to brolucizumab, or they were on bevacizumab and they were switched, I think a switch is important to try something with the patient to try to improve their outcome. And so in this case, the patient was switched to brolucizumab, and you can see that the results, the patient did great. And now we can attempt an extension. I think that, this case is unique because the patient really wasn't having a great visual response. And so I think that trying something different is a good choice, because the vision really wasn't getting that wasn't improving. And we'll talk about a scenario where you have persistent fluid in the setting of good vision. But perhaps Christina, you can maybe walk us through what you would do in this case.
Yes. These are challenging decisions, and it goes back to what you said earlier about the art of medicine, and that there could be probably a lot of different ways you're going. But I would probably, I couldn't tell, Jorge, is that a small little bit of subretinal fluid still at the edge of PED at the bottom slice, or was that?
It's a little bit of artifact there.
Okay.
It was mostly dry.
Okay, got it. So, if it was dry at this point, I would probably begin to extend. That's that's how I usually treat in these types of patients. And I agree with you that with rolosizumab, the one thing I do differently, without getting into the nitty gritty of some of the adverse events that have been, observed, is I do examine them closely at every visit. So I would examine them and tell them I'll be examining them every visit, but I would go ahead and attempt extension. Is that what you did?
Yeah, and that's what we did. And I think that, the point I wanted to drive home here is, if you feel that the eye has, more visual potential, and certainly, if you're not at the sort of limit of, let's say you're using bevacizumab and you haven't tried one of the branded agents, then perhaps it is worth switching to a branded agent. If you are on one branded agent, it may be worth switching to another branded agent, just to prove to yourself whether something is going to work or not. I think we'll talk now about the second option, which is, if this patient, let's say, was switched and didn't get any better, or, for example, could not switch because of insurance reasons, I might consider, if continuing to emphasize that a intensive treatment schedule is the best. But even with persistent fluid, I might consider extending if it's very difficult for the patient to come in every 4 weeks. And so, for example, this is a case where that decision becomes a little easier because there isn't that much fluid, and the patient's vision is very good. So you can see there that pigment epithelial detachment. There's a sliver of subretinal fluid, so the eye's not completely dry, but the vision's fairly good at 20/25. Is now on Q4 dosing, and there's really a concern that they can't come in every 4 weeks. It's just nearly impossible for them. And so again, the options are agent switch, continuation of Q4 week treatment, emphasizing that if it's not that much of an inconvenience, that perhaps they can find a workaround to come in every 4 weeks, or perhaps, and I'll show you a little bit of data that says that in patients with good vision and trace amounts of fluid, that we may be able to tolerate a gradual extension, considering this amount of fluid, the patient's new baseline, and extending so long as that fluid doesn't increase. And one of the most recent trials that looked at this was this trial right here that was published in 2018, and it's the fluid trial, and it was performed at different sites in Australia. And what they looked at was doing 3 monthly injections of ranibizumab in this case, and then treat and extending, and using what they called an intensive treatment schedule or relaxed treatment schedule, where they were tolerant of a small amount of subretinal fluid. And what you can see here is that the visual gains were comparable. If you look at that graph up there, in the long term, the visual gains were comparable. So if you have somebody that has some fluid, but for whatever reason can't come in every 4 weeks, or it's very difficult for them to come in every 4 weeks, you may consider, obviously, an agent switch, obviously pushing for continued 4-week treatment, but you may be able to consider a slight extension in these patients. So just to recapitulate, I think an agent switch is always warranted if you can. If not, I would continue to push for every 4-week treatment. But if that really is not an option, or is a difficult option, in the setting of a trace amount of fluid with relatively good vision, you may consider a gradual extension as long as the fluid does not get any worse. Christina, what's been your experience in that sort of patient scenario?
Yeah, it's interesting that you show that study, because they actually tolerated 200 microns of subretinal fluid, right, centrally. So it's actually a lot in that study, and it shows you that at least between the relaxed and intensive arms, the visual acuity still seemed to be comparable. And so it's data like that, and data like some of the post hoc analyses we've seen from our previous trials like Harbor, that have gotten me to start thinking a little bit differently about persistent fluid, especially if it's stable, especially if the visual acuity is not changing very much. I don't think I have a final verdict on that myself yet. I think it's an area we're all actively learning about still. I'm more open to the idea. The issues I have with tolerating fluid are, after how long of a period is it okay, right? Because if you go to the other extreme, then why are we treating to begin with? Because we know fluid in general is bad. So, but I think that there is a thought process that's starting to build in the community, and we're going to learn more about it as time goes on. But I think the way you managed that was beautiful, Jorge. I think it's very, very appropriate.
Yeah, and you can see here that we were able to extend out to 7 weeks, and I consider it sort of the last of those three options, right? I would try an agent switch. I would, if not, continue to push for, intensive treatment. But if I can't, I would rather try to tolerate a little bit of fluid and continue to treat the patient rather than lose that patient to follow-up because they don't want the injection. Because then I think that the outcome will most certainly be poor. And I always try to tell patients that, what we're guarding against is what that fluid represents, that, that fluid in and of itself may not, they may be seeing well with that fluid. They say, well, I have fluid, how come I see well? And I say, well, it's not so much about the fluid doing what it's doing now, but, where there's smoke, there's fire. And that's what I tell patients. And that fluid is a sign that there's bad things potentially are going to happen if we stop treating. So I always remind them that I worry about that big hemorrhage where they may lose vision that we can never get back. And so I think that helps with adherence. Mm-hmm. So let's move now to this case of sort of treatment fatigue. So this patient came in with new onset distortion. You can see here that they were originally 20/20, now they come in 20/40. There is subretinal hemorrhage on exam. You can see the OCT there with a small pigment epithelial detachment with subretinal hyperreflective material. And the other eye actually had good vision despite some early dry AMD. And so we started initial therapy with intravitreal bevacizumab. We eventually ended up switching to intravitreal aflibercept so that we could extend the treatment interval. And now the patient is 2 years out at a very comfortable, so to speak, every 3 month injection interval, but it's all relative, right? So whereas they were thrilled about the ability to extend out to 3 months early in the course of their treatment, right? It's what have you done for me lately? And they got used to this 3 month interval, and now that seems too much. And so, doctor, I'm tired of getting these injections. My scan and my vision are doing well. Do I have to continue? And I noted that somebody in the chat earlier said that they like to extend and maintain at 12 weeks, and I certainly think that is extremely reasonable. I think that 12, if you look at the pharmacokinetics, that 12-week interval is probably right around where the medication sort of maybe reaching a subtherapeutic level. And so, I'd be interested if the participants can write in the chat what they would do for this patient. And perhaps, Christina, you and I can talk about it, but the options here are if the fellow eye had poor vision. So in this case, the fellow eye had good vision, but if the fellow eye has poor vision, I'm pretty strict about not extending past 12 to 14 weeks. I tell them it's your only eye. I'd rather not gamble. All it takes is one extension and we may do poorly, and it's your only eye. So if the fellow eye has poor vision, I do not extend. And actually, I rarely will treat and extend past 12 weeks. I actually will usually treat or defer and observe, or defer and extend, where I will not inject this patient, but I make it clear that I need to see them back within 1 month for a repeat evaluation. And then in a similar fashion to treat and extend, I will observe and then gradually extend that observation interval. And again, I only do this if the fellow eye has good vision. Christine, any thoughts?
Yeah, this is always a troubling situation for me because there are some patients who can stop injections. It's a very, very small number, I want to emphasize. I used to do it more. I would call it a trial stop and do something very similar to what you're doing. I think it's smart that you're bringing him back in 1 month. I don't think I did that as tightly in terms of an interval. The problem is in that small cohort of patients of mine in where I tried the trial stop, I was burned a very small number of times, but it led to subretinal hemorrhages and irreversible vision loss. And so I tend not to do that as much anymore. There was actually a paper published or a paper presented at this year's Academy meeting that was virtual, that looked at that question of whether we can safely extend beyond 12 weeks. And the answer tended to be no. I mean, we don't have large trials looking at that, and you have to make the best decision for the patient. You know, just like you said, if you tell them no, you can't extend, and that patient doesn't want to hear that and doesn't show up again, you may be very much worse off than if you do this approach that you've taken. So I think as long as you've discussed it thoroughly with the patient and shared the data that we do know, I think it's appropriate to try. I tend to do it less myself nowadays.
Yeah. Let's see. I couldn't see. There was a question that came in the chat.
So there's one. Sorry, go ahead, Dr. Maysoon.
All right. Well, maybe we'll get to them. I'll just finish this case up, and we'll get to it here in a second. So this patient actually, because the vision was so good in the fellow eye, we decided to observe. And you know, for me, if I'm going to do this, I always bring them back within a month. Because of what you mentioned, Christina, and you know, AlTair and some of these other trials have shown that extension past Q12 weeks can be done, but it gets a little bit tricky. And so when they came back, they had fluid. And at this point, the patient, because I showed them the OCT, they understood this is what happens if we don't inject every 12 weeks. They felt, you know, better because we had tried. They now understood the consequences, and they understood that we were injecting every 12 weeks for a reason, not just because we had fallen into some routine. And so I think it improved the patient trust and confidence and compliance. And so now this patient is happily being injected 4 times a year at a Q12 interval. And so I won't reemphasize some of this so we can leave time for some discussion before we wrap up. But obviously, as Christina was mentioning, you know, treatment burden is sort of the holy grail of what we're trying to fix. There's treatment burden issues with patients, with physicians, with, you know, insurance companies telling us how often and what agents we can use to treat. So clearly, it's a big issue across all parties involved. Christina, you know, reviewed some of this data, but in the real world data, we don't treat exactly how we treat in you know, treatment protocols of these registration trials. So certainly we are seeing the real world effect there, where nearly 3/4 of patients actually receive less than 6 injections in the first year, which is nowhere close to what we see in randomized clinical trials. Here's another way of looking at this, where if you look at randomized clinical trials and you look at how that intensive treatment translates into visual acuity gains, we come nowhere close to that in real world evidence. And again, another way of looking at it, you know, unmet need. We don't inject as often as we should, and this is really why we lose vision oftentimes, and really highlights the need for a longer duration, longer acting treatment agent. And so, you know, the benefits of extended dosing intervals include optimal efficacy with a reduced treatment burden. However, the risks of extending dosing intervals include potential undertreatment with consequent vision loss. You know, regular visits and assessments, if not regular dosing, are the keys to maintaining visual gains. And the role of tolerating fluid as part of the treatment strategy is still under investigation, but has become an option to consider in a subset of patients. And so obviously we need a paradigm shifting, long-acting treatment. And as Dr. Wang mentioned, you know, the solution to all this may not just be a longer acting treatment, but the ability to monitor at home so that we can actually tailor these treatment strategies to each individual patient, thereby decreasing treatment burden. So great. Well, I'll open it up to any questions that may be pending.
Thank you, Dr. Fortune. I think we have a question from Dr. Ahmed, where Dr. Wang have answered him, but it's great to see also your input. Do you still use PDT in your practice? I mean, in general, not only in polypoidal, or it has been like obsolete?
Yeah, I think that it's always worth keeping everything in your armamentarium. I would say that in AMD, I'm less likely to use PDT. I think, a few years back, we really were focusing on this sort of combination therapy, where if we were getting lack of response from anti-VEGF monotherapy, we looked at PDT or we looked at adding steroids. At least in my practice, that's gone by the wayside. I still use a fair amount of PDT in my central serous patients. We probably don't see as much polypoidal in my region. I know, Christina, you have a large contingent of African American patients, so you probably do see a lot of polypoidal. I'm not a big fan of PDT and polypoidal because I feel that sometimes it precipitates hemorrhages. And so, in general, I just mostly do anti-VEGF monotherapy. But I think that that's the beauty of medicine. I think that you have to tailor treatments to each individual patient. And there certainly is a subset of patients that may still benefit from some PDT in very poorly controlled disease. So, Christina, I don't know, are you still doing anything but anti-VEGF monotherapy for your difficult to treat AMD patients?
I use it rarely. I think it's one of these endangered species in our armamentarium where we don't use it as much. And I'll be honest, I would say most of my retina friends and colleagues don't have availability. They don't have access to a PDT machine. I still use it on occasion. It's seldom in the setting of AMD. I will do it for patients who I've switched, across anti-VEGF agents and still have incompletely responded, even on a Q4-week basis. I'll use it in those situations, and I've had good success in the very small number of patients I've treated that way. I actually do like PDT for my PCV patients. We do have a fair number of those. They tend to do well, but I'll also use it in combination with anti-VEGF, like you were saying. And it is my treatment preference also for central serous retinopathy, but only if it's persistent. If they've had symptoms for over 6 months or continue to have chronic recurrent subretinal fluid, then I'll pull it out for that as well. But it's a good tool to have. I think anti-VEGF works for the vast majority, though, which is reassuring.
We have another question, I think. For CSCR, you use half dose or full dose BDT?
I use half dose, definitely. I don't think that there's really much of an indication for full dose PDT nowadays. I think you run the risk, particularly in perifoveal disease, for shutting down the choroid completely and eliciting sort of permanent vision loss. So I use half dose PDT. I've also recently started to use micropulse. We recently got a micropulse laser in one of our practices, so I've had some varied success with that. But PDT does work quite well in CSR, and I think half dose is more than enough.
So I don't think we have any more question in the chat box. So I think we are reaching to the end of this informative presentation and fruitful discussion. And it's actually great to know and acknowledge that effective communication can as well help us to overcome lots of our treatment difficulties. I'd like to thank our speaker, Dr. Wang and Dr. Fortune, for this lovely presentation and I'd like to thank our participant for the lovely discussion. I would like to thank Novartis and Emerging Society of Ophthalmology as well for supporting this program tonight. And I think, Shruq, you've placed the link to the CME. This session tonight has 4 CME hours, and I think there is a link in the chat where you can click on it to obtain your CME hours. Our next series of this program, which was initiated by Novartis in collaboration with AAO, will be, I think, as follow-up for wet AMD sometime in September. Looking forward to meet all of you again. Thank you very much and have a great evening.
Thank you all.
Thanks, everyone. Bye.
Thank you guys again for the invitation to participate. We appreciate it.
Thanks a lot.
Thank you, Shuruq.
Have a good night. I realize it's late for you.
Thank you.
Get to bed.
Thank you. Thank you.
All right. Take care. Bye-bye.
Really
Take care.
enjoyed that discussion. All the points highlighted. So have a great evening.
Thank
Bye.
you very much. Bye.